Our next speaker is Dr. Julie Kanter. So she's here to talk to us about hemoglobin SC. So Dr. Kanter is a professor of medicine and pediatrics at the University of Alabama at Birmingham School of Medicine. She leads the Adult Sickle Cell Center, despite being a pediatrician, and co-leads the Lifespan Comprehensive Sickle Cell Center. So she has two main research focuses: advancing novel therapies through improved understanding of biology and clinical endpoints, and using dissemination and implementation science to improve access to care in sickle cell disease. So Dr. Kanter has received funding from the NIH, NHLBI, HRSA, and the CDC. She's also the president of the National Alliance of Sickle Cell Centers, the first network of sickle cell centers dedicated to reducing barriers and improve access to quality care for people living with sickle cell disease. So a very warm welcome to Dr. Kanter.
Thank you for that excellent introduction. I always hate hearing someone talk about me. You're like, you want to hide. And thank you so much for having me here today. Really, really appreciate it. Really appreciate being here. And from the National Alliance side, really excited to collaborate with CanHaem. I think there's a lot of things that we can do, and I've found in general, the more we do together, the better we do. So let's take a hard right from beta thal major to hemoglobin SC disease. I think their similarity ends with the word hemoglobinopathies in a lot of ways. These are my disclosures, not really relevant at all to what I'm going to talk about today. So hopefully we can briefly review pathophysiology of hemoglobin SC disease. I'm not going to spend too much time on that. I apologize ahead of time. There's too much written on my slides, but I'm not going to read every line, but I'm happy to share the slides. Identify some of the complications that I think people aren't always aware of affecting individuals with SC disease. Talk about the many gaps. What we don't know is far more than what we do know, which I would say is true of a lot of sickle cell disease, but especially in SC, and some of the interventions that are being developed that I think may help us improve some outcomes. So it's our second most common type of sickle cell disease worldwide. As you know, about 50% S and about 50% C, give or take. And these don't really mirror what you'd expect if you saw one person with sickle cell trait and one person with hemoglobin C trait, right? It's the marriage that causes problems. And we know the prevalence in the US and the UK as well. I didn't know this. I didn't realize that hemoglobin C was actually even more protective when you have hemoglobin C trait than hemoglobin S trait from malaria. And I didn't know that hemoglobin C mutation first occurred mostly in Burkina Faso. I thought that was really interesting because, as you know, we can see quite a lot of how sickle cell disease has developed over time by watching immigration patterns. The pathophysiology here, don't want to go into too much detail because you might fall asleep, you just had lunch. But we know that our hemoglobin C-laden red cells have this tendency towards crystallization and cell dehydration, and a lot of questions around the hemoglobin C-induced loss of potassium in water that increases cellular dehydration. So that dehydration here is much more profound than we're seeing in individuals with SS-type disease. And this really contributes to that pathology that I'm going to talk a little bit more about. Another thing that I think we don't talk about enough is my friend band 3 in the red cell. There are a lot of people smarter than me in red cell biology that could tell you more. But remembering that band 3 actually plays quite a role in the adhesiveness or non-adhesiveness of the cell. It's actually not just the polymerization of hemoglobin in sickle cell disease, but how the hemoglobins themselves interact with band 3. And similar to hemoglobin S, hemoglobin C does have that interaction. So these are just some great pictures. Why not a little electron microscopy for dessert today? You can see the presence of the large visible erythrocytic crystals in circulating red blood cells. And this was actually just on a free stick that was done in a clinic, dropped right into buffered formaldehyde. We know that people with hemoglobin SC and alpha thalassemia have the lowest MCVs, and they actually don't exhibit those crystals. So what's the morphology and density? Well, the density has a lot to do with the pathophysiology. We know that hemoglobin SC cells live for about 40 days, so a little bit longer than those with SS cells, but of course not as long as the average red blood cell. We also know that the red cell density is directly related to the MCHC within the cells, and that all red cells that have hemoglobin C, whether it's hemoglobin C trait or SC disease, are actually denser than the normal red cell. And this is also important because the cell density has a lot to do, we think, with the pathophysiology. This is a really important paper, and I want to spend some time on it because it was just recently published, and I think it's going to introduce some concepts that are going to be really important long-term. So we've talked a lot in recent years about ectocytometry and how we're going to use that to better understand hemoglobinopathies and sickle cell disease, both how sticky they are and what that point of sickling is, and then what does that even mean. What this was a study that looked at SS, people with SS disease, people with SS and hydroxyurea, people with SC, and people with SC and hydroxyurea. And those blue arrows, those are telling you what we're talking about right here, which is the SC side of things. And ignore all the significance, because as you can see, everything in this study was pretty significant. But what they looked at was the maximal red cell deformability in normoxia, so in normal oxygen conditions, and then in hypoxia. And the point at which that cell starts to sickle is what we're calling our point of sickling. And there's a lot of interesting things about that. But here I want to point out two interesting things from this study. The first was the point of sickling was lower in the two hemoglobin SC groups compared to those with SS disease. And even more interesting to me was that the percent of red cell deformability recovery, so the point at which you can unsickle a red cell, is worse in SC disease. So once those cells become abnormal and deformed, they can't get fixed nearly as easily. And we're going to touch on that again when we talk about multi-organ failure syndrome, because I think that's a big part of what's happening. Some other noticeable findings from here. When they looked at hydroxyurea and viscosity, they saw that blood viscosity was not different when they compared SS samples with hydroxyurea and without. But when they looked at samples with individuals with SC disease with and without hydroxyurea, they had greater blood viscosity than those with SS without hydroxyurea. And people with hemoglobin SC with hydroxyurea had lower blood viscosity than hemoglobin SC without. So when we start to think about how is hydroxyurea working in this population, we're going to go into that a little bit further as well. So the important question, and what sort of triggered my interest, is it really less severe? Because we walk around and we say that, and then you see my 40-year-olds in my clinic who clearly are not less severe because they have hemoglobin SC disease. So historically, this was really characterized as that mild type of sickle cell disease. And I think we did a lot of damage, especially now, because parents were told this. They were told your child's going to have mild disease, no problems. Suddenly, this young adult grows up, has all kinds of pain, and shows up with no understanding of their disease and a lot of opioids in the United States. And we know this. It's incredibly heterogeneous, and that heterogeneity extends towards people with hemoglobin SC disease, where I'll see some people who have never been sick. I diagnose about one new patient in adults every other month who are 50, 55, 65. I see lots of heads nodding. I know it's not a US problem. And many of these individuals have never had true acute crisis, and so they were told they were fine. And we know that in children, they certainly have a lower risk of stroke, a lower risk of sepsis, and they have more normal growth and development. But we know that all changes when they hit adulthood, and that suddenly this disease changes dramatically. We also are seeing differences with hydroxyurea use, as you might imagine, in children versus adults. That's going to affect long-term, I think, what happens in this patient population. Of course, aging itself, well, we all know this, right? Aging is a risk factor for everything. Everything seems to get worse as you get older. Trauma, physical injury, everything, and that goes with your endothelium as well. Endothelium is aging, and it's aging faster in people with sickle cell disease as they incur more and more damage. And in some ways, I think that's what's happening with our individuals with hemoglobin SC disease, is the endothelial damage is catching up with them. And I always tell my patients, I want them to think of the red cells as the cars, and some of you may have heard me say this before. And if you imagine the blood vessels as the road, right? If the cars are constantly driving on the road, we know there's going to get road damage over time. If you live in New Orleans, where I'm from, you get road craters over time because they're never fixed. And we live below sea level. In some ways, some of our patients live below sea level, right? We know their blood vessels get even more injury. And the same is true here. But not only do the cars have more wrecks when there are more of them on the road, as the case with SC disease, but there are more of them on the road, and they still have all that endothelial damage, which I think explains how that viscosity and endotheliopathy go together. For the record, when I explain this to my patients, a lot of them have this aha moment. It's something they can picture and really understand, and just for fun, you can throw in the garbage trucks and the 18-wheelers. Those are the white cells. And then the motorcycles are the platelets, and it's a lot of fun from there. So as people got older, we asked this question. Now, we did this study a few years ago, big collaboration called the Sickle Cell Disease Implementation Center Study, funded by the NHLBI. And there were some issues with this study, but some good things came out of it as well. People were enrolled from 15 to 45, and then we looked at various complications, and this was a registry, and part of the problem was that, like almost all good registries, they're gonna end when the study ends. It's not really a registry. We're gonna fix that as time goes on, and hopefully we can cooperate with CanHaem on that. But the problem here was that we don't actually know what happened to the older individuals, because you couldn't enroll in this if you were over 45. But we looked at individuals from here, they all got a baseline assessment, and they got 2 follow-up assessments. It was a registry, and it was a convenience sample, right? We didn't call everybody on our database. We enrolled whoever was in the clinic. It was done in 8 different centers. We looked at comorbidities, laboratory assessments, patient-reported outcomes, and acute care use. And then we performed this very complicated statistical analysis that I'm not gonna say correctly, so I'm not really gonna try, but I put it on the screen for you in case you were really interested. The basic gist is we did 3 different sets of odd ratios, where we first used a case control method of comparing individuals with SC to SS disease, because there are a lot more with SS in our database. Then we looked at the age in that model, and then we looked in the third set by a single run for each outcome with the genotypes of interest. See, told you I wouldn't get it right. Here's some of the information that we found. Demographics, I think the most important thing I wanted to call out is that the mean age of the patient population was the same, which I thought was interesting. So yes, we're only enrolling this certain group, but we still have the exact same median age of 28 years of age. And we saw, overall no significant demographic differences. When we looked at sickle cell disease complications though, and you can see here blue is SC and red is sickle cell anemia of all different genotypes. The y-axis is the number of participants and the x-axis is each individual complication. The first thing was, unsurprisingly, most people with SC disease had less complications overall than the population with SS disease, but almost everyone had at least one severe complication. The second really important thing that we saw was a significant increase in splenomegaly. I'm well known as the spleen reaper, so in contrast to thalassemia, I think that we should take out everybody's spleen with hemoglobin SC disease because I've seen such severe splenic sequestration and hypersplenism causing all kinds of problems. And also the amount of retinopathy, right, was twice as much as what we were seeing in sickle cell anemia. We know that, but yet our individual patients don't. And here they were told that they had this less severe disease, so they're really wondering why they're going blind. We also saw a really larger percentage, a slightly larger percentage of anxiety and depression in our population with SC disease versus SS disease that I think was not expected. We also saw a lot of AVN, even though there's a little bit more in the SS population. We saw more pulmonary embolisms than we expected and a frequency of acute chest. These were those odds ratios that I was just telling you about. The odds ratios less than 1 here indicate lower prevalence in hemoglobin SC disease, and the bolded findings really show you significance, and quite a lot of this is what we've already talked about. When you were greater than 1, it was what we saw more of in the SC population, so those areas that I just told you about. What about pregnancy? Now, pregnancy was not studied in my favorite way. You like my Aladdin picture? You can find all kinds of fun things when you Google with images. Anyway. So pregnancy we didn't do this my favorite way in this study, but I wasn't in charge. Here we asked patients to report on their pregnancy outcomes. We didn't necessarily go back and look at the medical records for these pregnancy outcomes, so just have an awareness of that. But we did see a lot of pregnancies in our cohort, and we saw a comparable amount of miscarriages in people with hemoglobin SC compared to those with SS. We also saw quite a lot of people with premature children or with intrauterine growth restriction, very similar to SS disease. We really tried to assess if certain complications, specifically retinopathy, was associated with higher hemoglobin levels to try to add more proof that this was a hyperviscosity issue related to hemoglobin, and sadly we were unable to show you that at all. And that was true for everything we looked at, actually. AVN, retinopathy, there was no association between higher hemoglobin, whether we made that cutoff 10 or 11 or looked at it as a continuous variable. So what did we conclude? Obviously that people with hemoglobin SC disease should no longer be considered to have mild disease, but maybe said more clearly they may have worse disease as they age, and the most important is they need to not fall out of care. Because that is what we see as one of our primary issues, is they stop going to clinic when they're 5, they show up in my adult clinic a hot mess when they're 25. So how can we prevent that? That's an ongoing discussion. Well, what we are not able to study well is multi-organ failure syndrome, and I have a real interest in this area. It's been called different things, but you know it's when you see the patient and everything is going wrong. That's a pretty well good definition, right? Originally defined by my friend Kathy Hassel in 1994, where they described 17 episodes, 14 adults, some with more than one event like this, and they defined failure as more than 2 organ systems down at a time. They looked at the genotypes in this group, and it was more SS than SC, but since then we've seen a number of other case reports. More, if you summarize all those case reports, are actually occurring in SC patients than SS patients. Why? Probably because more of those were people they didn't know had sickle cell disease when they walked into the room, and so it becomes a surprise, so of course somebody wants to write a case report about it. What happens with it? Well, we know a lot. We know that there's this progressive vaso-occlusive crisis, and I always tell patients, you don't really die of pain, but you can die of a severe diffuse vaso-occlusive crisis where you have literally hemolysis everywhere, essentially. In this scenario, when you look at all the different reviews and studies, SS and SC occur pretty similarly. But when we see fat embolism syndrome, that tends to happen far more often in those with hemoglobin SC disease. Disproportionately so. Now again, they're also disproportionately not followed by hematologists. So we have to wonder how much that plays into their outcomes, but they have worse outcomes overall. And this brings me back to that idea of, well, if their cells can't recover at all because they're forever deformed and no longer able to reverse their deformity, that may be having something to do with it. We of course see hyperhemolysis and alloimmunization related multi-organ failure syndrome as well that tends to occur in all genotypes. What about our more contemporary registry? So as I mentioned, we've done a really bad job, really overall in the US with hemoglobinopathy registries, but specifically in sickle cell disease, where we've done a registry, we get a grant, we're really excited, the grant goes away, so does the registry. We're attempting to alleviate that with this registry called Granddad. I apologize, I did not name it. If I had, it clearly would have been Grandmom. But it's the Globin Research Network for Data and Discovery. And it was actually started by my colleagues Jane Little and Sophie Lanskron over 10 years ago now with a small Doris Duke grant. It has now evolved to become our National Alliance of Sickle Cell Centers registry. We have over 70 centers now accruing on this. As you can see here, I wanted to look at what we were at this time in the data cut, about a fourth had hemoglobin SC disease, just to get a sense of whether or not this mirrored what we were seeing in the SCDIC study. You can see the breakdown here of children and adults. Again, interestingly, the mean age was 28 years. Now it was interesting because in this registry, we enrolled from birth to death, and the oldest patient in this registry was 80 at the time. And the complications that we saw were also quite similar, with 25% of people with SC disease with avascular necrosis, 25% with a history of acute chest, and about 8% with splenic sequestration, which was higher than that with SS disease, as well as almost 10% with a history of PE. But we also know one of our biggest problems is, what do we offer these individuals with SC disease? It's our second most common type of sickle cell disease. You already have a neglected condition. It's the neglected of the neglected. They weren't included in the multi-center study of hydroxyurea, and we know that this is often because their clinical and laboratory findings are very different than that with SS disease. On it being a good statistician, which I am not, the answer to that question is accrue more patients and stratify your patients by genotype at the beginning. We know they also weren't included in our stroke trial, so we don't know a lot about those individuals who have had a stroke because they weren't in the trials, and we know nothing about TCD in this cohort. The recent trials, the HOPE trial with voxelotor, the ongoing HibIscus trials of etavopivat, are open to all genotypes in theory, but they have an upper limit of hemoglobin of 10.5, so as we know, that really limits the number of individuals with SC that are going to be eligible. This population was included in the SUSTAIN study, but unfortunately, it was not included in a statistically significant way. In other words, they did not stagger enrollment to ensure we had enough people with SC disease to make a convincing argument. So with the world and our pharma companies and our friends seeing this robust excitement about sickle cell disease, we need to really impress upon our pharmaceutical colleagues the importance of developing therapies and studying this population individually. And we have a really cool new friend. Not the ones in my kitchen, not as cool. But most recently, we have two groups, one in Cincinnati and one at St. Jude's, that have actually developed a Townes mouse that's going to need a new name because now it's the Townes mouse with SC disease using fancy CRISPR. We have finally a mouse model of sickle cell SC disease, which is the first time we've had this. And they've done a couple of really interesting studies, Of note, they do resemble people-ish. I mean, we have different ears, but in that they have moderate anemia, they have severe red cell dehydration, just like clinical hemoglobin SC disease. They have a higher whole blood viscosity, and they have target organ damage very similar, and most notably, significant progressive retinopathy, much worse than the standard Townes mouse. So there are certainly some things we're going to be able to study with this mouse. So they took their new friendly mouse and they studied hydroxyurea, and I think they found some really interesting things here. They saw a lower, as we know if you use this clinically in your SC population, but still modest increase of hemoglobin F, but really only about up to 7%. My friends who do mice, I hate mice research work, tell me that it's actually pretty easy to induce fetal hemoglobin in a mouse, easier than in a human, so the fact that they were only able to get it up to 7% tells us that these are less inducible. But interestingly, as we saw in the ectocytometry study, the hydroxyurea improved red cell deformability in this population, even without that hemoglobin F induction, underscoring the hemoglobin F independent effects, which we all know are there, but were really first pointed out in this mouse in the hydroxyurea population. So they also saw other improvements, including lower feral hemoglobin levels, reduced Heinz body formation, and better red cell stability and membrane stability. So it underscores a lot of what we already knew, that hemoglobin SC is clinically distinct, not perhaps just a milder version of SS disease, and it has unique pathophysiology. There's some other things that we do know about this population as well, and I'm going to go right over here to the PIVOT study. So the PIVOT study was recently published as well, because you can't seem to get funded somehow, even if you score 14, as my colleague Dr. Ware did, and he had a great name. It rhymed with twitch and switch, and it was niche, I think, for hydroxyurea in SC disease. But anyway, it never got funded, but they did fund one in Ghana. They did a phase 2 trial in Ghana in children and adults, but in my very opinionated opinion, maybe asked the wrong question. They looked at starting 20 mg per kg of hydroxyurea right away. These are pediatricians, they don't take care of adults. We almost never start hydroxyurea at 20 mg per kg like in a 50-year-old, you just don't do that. We all know that they don't tolerate it as well, they have a harder time. And the primary endpoint wasn't necessarily to assess pain crisis, but to assess dose-limiting toxicities. So a little bit of a different study than the original multi-center study, and the study did not meet non-inferiority, because as we also know, many people with SC disease have lower white counts to start with. Plus, with big spleens, they have lower platelet counts, and makes the dose-limiting toxicities much faster. Most of these cytopenias were, of course, not life-threatening, they are mild and transient, but it did, unfortunately, result in this study ending earlier. And while they saw some efficacy sides, we saw fewer VOCs and fewer hospitalizations. The study wasn't powered for that endpoint, and it was ended before then, and a more definitive trial is still needed. So let's switch gears a second towards iron deficiency in sickle cell disease, because there are several reports, mostly case reports and small case series, in which retrospective reports have shown us that repetitive phlebotomy may improve outcomes in hemoglobin SC disease. In fact, in a meeting with some of my French colleagues, I mentioned something about individuals with SC disease having a lot of pain, and they kind of looked at me in that fabulous French way and said, just take their blood, just phlebotomize them. Sorry, terrible accent, I'm aware, but I can't say it in French either. But they really rolled their eyes at me, were like, what are you doing? Why are you not using therapeutic phlebotomy? Because it was so used routinely in their clinic. And this is Pablo Bartolucci, so you can tell him I said that. And why do they do that? Well, it results obviously in iron deficiency, which causes a lower MCHC. And it's unclear if the iron deficiency itself is driving the improvements, or if it's driving other improvements related to just having less red cells, right? Less cars on the road, less traffic, less accidents, less adhesion. So looking at this a little bit further, there was an observational study in the Netherlands that looked at people with hemoglobin SC disease, specifically not taking Hydrea and not recently transfused. And they also examined similar laboratory parameters as we discussed before, with dense red cells, blood viscosity, and red blood cell hydration, and they also assessed point of sickling. They included 47 individuals here with hemoglobin SC disease, ranging from 6 to 66, and 16 of those had concomitant alpha thalassemia. So they found that, unsurprisingly in some ways, ferritin positivity correlated with reticulocyte. It also correlated with blood viscosity and CRPs, and these results indicated that lower ferritins were associated with lower reticulocytes. Probably knew that, but that also lower ferritins were also associated with lower blood viscosity, which we didn't know and was quite interesting. Increased red cell dehydration and lower levels of inflammation. And the rate of sickle cell disease complications was significantly lower in the patients who were iron deficient compared to those with higher ferritin levels. So this seemed to say that iron deficiency was associated with a lower retic count, lower blood viscosity, and better outcomes. At another center treating 179 patients with hemoglobin SC disease, they found that 64 patients qualify for a similar study in therapeutic phlebotomy. Their qualifying characteristics were having a hemoglobin greater than 10.5, having at least one pre-specified complication as listed. And they targeted a hemoglobin of about 9.5 to 10 when they were doing phlebotomy. And they noted a good clinical response in 71%, which they defined in numerous ways: decreased acute care, decreased pain, absence of other new spleen infarcts, and other things. And so when we tried to understand how we could do this, we actually mirrored this initial study that was the French study, who they told me, why aren't you just doing this? And here they did something similar. They had 100 patients in their group, 27 with SC disease. Similarly, the main complications were pain, as well as retinopathy. Their median age was also similar. They had 21 in this group that they included for analysis, and the hemoglobin initially was 12 at baseline, the LDH of 323, the bilirubin 1.3, so very similar with a ferritin of 68. They did repeated phlebotomy, each time giving 500 mils of fluid, and they did this every 7 to 14 days, which I thought was really interesting, because getting people to come back to your clinic every 7 to 14 days is not necessarily easy. And that they found, unsurprisingly, that the more they did phlebotomy, the lower the hemoglobins got. I mean, that was a good outcome, but I'm going to write a study like that soon. So the median hemoglobin went down by over a gram, but they did find this also was associated with improved hemolytic parameters, as well as complete or significant improvement in their pain. And they interestingly reported an improvement in fatigue despite a lower hemoglobin. So this was decided to be highly acceptable and something to also continue. So why is this? Why would it work? Well, the phlebotomy-induced iron restriction can result in both decreased hematocrit, but is also the MCHC going down. And clinical severity in SC disease is really thought to be due to this abnormal blood rheology that is different than the blood rheology we're seeing in SS disease, and it's driven in a lot of respects by that higher hematocrit. More cars on the road, more concentrated, dense cars. Thus, the clinical improvement might be due to one or the other, or both in a combination. So this is what we need to understand. So now there's some new drugs that are actually looking at this question. There are drugs out there that are now targeting iron restriction. And it's a really interesting pharmacology that I would butcher if I tried to tell you about it, but the beginning of it is that they mimic hepcidin activity as a way of restricting iron. And the original idea, I think, behind some of these therapies was to look at if this would help with iron overload, but it doesn't really seem to, because the iron differential isn't that much, but it does help with the iron loading in the red cells. And so they've been considered, as I mentioned, initially for iron overload, but are now being considered for individuals with frequent pain. And I'm urging most of these companies to really focus their studies on SC disease. We did have one study already of vamifeport that we presented at ASH, I think last year, where they looked at SS disease. But balancing that anemia is like on the point of a nail is pretty complicated. So this is expected to induce an iron-restricted erythropoiesis, and that's the goal. So vamifeport was the first one studied. Again, it started in SS disease, and in this case, it was a small molecule that bound to ferroporotin and directly blocked the iron export from cells, inhibiting the dietary absorption and iron release from liver and spleen macrophages to induce this iron-restricted erythropoiesis. The result was hypochromatic microcytic erythrocytes with hopefully reduced hemoglobin MCHC, or mean hemoglobin concentration. This is the proposed way this all works. Not going to go through it in too much detail, but I thought it was really quite interesting. More recently, there's another study coming to fruition that will be including individuals with hemoglobin SC disease. I do consult for this company. I did beg, plead, and maybe tried to bribe, but it failed them to include individuals with hemoglobin SC disease, but I get no revenue from that, and there is no data for me to share with you, so nothing confidential and all available on clinicaltrials.gov. But it is a monoclonal antibody against TMPRSS6, and it's to increase the endogenous expression of hepcidin. They're not only studying this in sickle cell disease, but also in PV. And they initiated this study by, again, increasing hepcidin as a way of reducing iron levels to have that same effect as therapeutic phlebotomy, but perhaps easier. This is the model that they're using, adapted from the recent poster that they presented, really trying to show you where TMPRSS6 is in this complicated scheme of iron. So what about other novel hemoglobin F inducers in SC disease? Is there an option for therapies here? Well, in contemporary SC cohorts, we know that baseline hemoglobin F is low. Most individuals untreated sit around 1% to 2% of fetal hemoglobin. The PIVOT study specifically reported that the mean baseline hemoglobin F was 1.8%. And we would think that mechanistically, any increase in fetal hemoglobin will, of course, abrogate the effect of SC as a combined abnormality in each red cell, and that would dilute it and reduce the polymerization. The mouse data suggests you can get modest rises with hydroxyurea, but there may be other newer drugs that have less dose-limiting complications because they're not bone marrow suppressants. So what do we get from all of this? Well, I think there's hope. I'm really excited about some of the new agents that are going to induce fetal hemoglobin because I think we'll have a better chance of using them effectively to assess their use in hemoglobin SC disease, though I can't say for sure whether that effect will have the same use as hydroxyurea. Again, realizing that I don't think we completely understand if hydroxyurea derives its most benefit from fetal hemoglobin versus its anti-inflammatory properties. We can certainly say that at least in adulthood, hemoglobin SC disease is not less severe, especially as people age, and that both the SC-DIC and granddad cohorts showed us that almost everyone who is at least 16 years of age had at least one major complication from their hemoglobin SC disease, and many with multi-organ complications. And that the disease is different and needs attention both in the lab and in the clinic to improve outcomes for affected individuals. Otherwise, we're going to keep doing the same thing over and over again and thereby define Albert Einstein's definition of insanity. So, some quick take-home points. Most important, we have to ensure these individuals stay in care. We found the biggest failure to transition in my population when I arrived at UAB was the failure to stay in pediatric care. If you made it to the transition doorway, 95% of the time you walk through and you come out on the adult side. Who was the most likely to not transition? It was everybody with hemoglobin SC disease. When you broke that down, you could see it was people not on transfusions and not on hydroxyurea, which was everybody with hemoglobin SC disease. So we have to recognize also that these individuals present a unique place in the healthcare system. I've had numerous individuals who presented that were not aware that they had sickle cell disease. One last quick story is I have one of my most favorite patients ever. She was 54. And she was seeing rheumatology for rheumatoid arthritis. And they had in their notes, patient experiences periods of pain lasting 3 to 7 days of unknown etiology, often associated with anemia from which she has trouble recovering, and never tested her for sickle cell disease. You just had to be kidding me. So remembering that when I look at blood, I think of sickle cell disease and hemoglobinopathies right off, but perhaps not everyone sees the same thing that I do when we're looking at a CBC. And so reminding our colleagues that these individuals exist and may not have been diagnosed as newborns because a lot of our younger physicians think everyone's been diagnosed as newborns, which we know is not true. Also educating our medical providers that they present a unique need. Splenic sequestration. People are constantly surprised when I tell them, no, not everyone loses their spleen and it continues to be a problem. It's important the individuals receive very appropriate, coordinated clinical care, just like our individuals with SS disease, and of course, just like our individuals with thalassemia. And that they must be included in more clinical trials in a statistically appropriate way to power our assessment of outcomes. And I am looking forward to the future. Happy to take any questions. And I think you're supposed to scan that QR code because somebody sent it to me.
Yeah, Jacob Pendergrast, University Health Network, Toronto. Julie, that was so great, so interesting. In terms of my own practice, I'm definitely sort of siding more with those French people, and I push the phlebotomies, and I've had good outcomes with it. I think, just the one thing I would ask, as we start getting ready to do actual clinical trials in these patients is to remember to do the thing that we keep forgetting, especially in transfusion trials, which is where my other interest is, which is to make sure we keep asking the patients what they prefer. And I think, very often we make some assumptions about, what is easier or harder for them. And absolutely, I've had a few patients who don't want to come down to the hospital to get their therapeutic phlebotomy. They say, I'd rather just take a pill than come downtown. So that's for sure part of it. But the other thing about phlebotomies I think is important is that the frequency with which you have to do them gets lower and lower over time. And I've had patients who have to have a phlebotomy. They have an induction period for sure, and then afterwards, like maybe once or twice a year, it's all they need. And I think it's really important to keep that in mind. I would hate for us to like do a trial of a very expensive hepcidin inhibitor and conclude that that is standard of care because it's easier for the patients, unless we have actually asked the patients what they would prefer. So that would be my only.
I think that's a great point, and I've talked to some of these companies about once they, we'd get through a phase 1 and phase 2, if we're seeing efficacy, that we consider actually a 3-arm study of the phlebotomy versus an agent such as this. But I think that patient satisfaction is incredibly important because it's hard for them. Parking in my institution is a disaster, and they'll do anything not to come. Dr. Coates, you get to go first.
Thank you very much. Yeah, fantastic presentation. And I got to admit, I'm still shocked by this because we're very, very aggressive about using hydroxyurea in our SC patients. And we can point to many patients who get fetal hemoglobins over 30% in their SC. So, this whole idea that you don't get a response in fetal hemoglobin with hydroxyurea to me is false, because we've been doing it and we've had many patients with a lot of pain. They go on hydroxyurea, they do very well. And actually, the Russell Ware study you pointed to showed very clearly that it doesn't increase the hemoglobin, which is I think what everybody's fear was. Yep. Oh my gosh, their hemoglobin's going up. It doesn't increase so that was one of the best part of that. Yeah, I totally agree. Their primary outcome was totally wrong. So it's because it was an excellent study, except it had the wrong primary outcome, which seems to happen time and time again in sickle cell disease, which I don't understand that, but anyways. Yes, so that was just my plea is if we're gonna do anything, like hydroxyurea works in SC.
I actually absolutely agree, and I've seen very heterogeneous results. I have seen the people that I get 20 to 30% fetal, and then I have some that swear up and down that they're taking it, and I don't see that fetal hemoglobin change. So I think understanding that is equally as important as well. Dr. Coates.
So just to be argumentative here, I think fetal hemoglobin is highly overrated.
Not disagreeing necessarily.
And a question, and then I'll come back to that comment. Do you remember in the mouse, I've seen the SC mouse papers. Do you remember what happened to their MC? Because you noted that the fetal hemoglobin didn't go up that much. Do you remember what happened? Did they look at the MCHC?
They did. It decreased.
Okay. Because I just pulled up the paper by Beeman and the group. I'm on the phlebotomy paper. And the MCHC substantially decreased in that group as well. So, sorry about this, but delay time to polymerization of, you know where I'm going with this, the delay time to polymerization of hemoglobin S is inversely proportional to the negative 30th power of the intracellular hemoglobin concentration. So that means a tiny, tiny decrease in the intracellular hemoglobin concentration greatly prolongs the time between deoxyhemoglobin formation and polymerization. Fetal hemoglobin only acts by diluting the intracellular hemoglobin S concentration. There are other ways to do that, like make the cell macrocytic and therefore drop the bigger volume, same amount of hemoglobin, you drop the intracellular concentration. So it's great if your F goes up, but it's well known that you can get an effect with hydroxyurea even if the F doesn't go up.
Excellent, thank you. All right, thanks everybody. Oh, sorry, one more question.
Thanks. Thank you, great presentation. And I'm very happy that the organizers focused on the hemoglobin SC disease. Uma Achale from McMaster University. Just the concept of the milder disease, and I think we as a medical community do need to do more, because a lot of times our residents, fellows, and even some physicians don't understand the concept of double heterozygosity. What is told to the patient is that yes, you are a carrier of S and you are a carrier of C. and they don't read or understand that this is sickle cell disease and can be pathognomonic. So just wanted to kind of...
Absolutely true. I actually had a patient referred recently with sickle trait and beta thal trait.
Yeah, and that's
But-
a common problem.
My question is, I have patients with on exchange transfusion as well who become iron deficient, and the advice we get from iron clinics is replace the iron before they get symptomatic. And now I'm wondering with my phlebotomy SC patients that are getting iron deficient, I actually was targeting a hematocrit that's lower, not an iron that is lower. So I was considering also replacing the iron. But am I chasing my tail that way?
So I think it's a great question, and it's actually something I did return to my French colleagues and ask them, because they do have the experience, and they maintain a ferritin of about 10 to 20 in those individuals. So they are relatively iron deficient, and I do replace iron to keep them at that level. And I think you want to comment on that?
Yes, thanks. Actually, it's very challenging with the iron. So what I did is I went to see my colleagues who do phlebotomies in polycythemia vera, and I asked them, how do you know when you remove too much iron? And so we made up a little questionnaire with all the PICA symptoms, and I tell patients, like, if you really have like restless leg syndrome, if you start to crave for non-food items like chewing on ice, and I have this whole list, and it sounds very weird, but I tell the patients, like, this is very weird, but if that happens, tell us, because that means maybe we remove too much iron. But we don't want to supplement, because that would just mean I have to do more phlebotomies, and that works. And what we are also doing is when we have SC patients who have low ferritin, we just don't replace, like if it's due to menstruations and stuff like that, because there's this feeling that it might help them. But I think that should be included in a trial as well, to have a specific questionnaire that goes beyond just extended quality of life. I think you have to really, even like, how is it focusing, how's your mood, like this can all be affected by low iron. But most of the patients actually feel so much better that, like, I know you're asking me this, but I feel really good. Even if it wasn't so much for the pain, it's just overall, some tell me they have more energy, which is surprising with lower hemoglobin. So.
Well, thank you all very much for your attention and questions.